Next, let's look at the muscles of the posterior abdominal wall individually. Our first one will be the psoas major, so we'll want to understand its attachments, its innervation, and actions or functions. The origin of the psoas major, and we can see several points of origin in the illustration. Here's the right psoas major. The left one is shown over and through here. The points of origin of the psoas major will be the vertebral bodies, their lateral aspects of T12, L1, L2, L3, L4, and L5, the intervening intervertebral discs, and then it also will originate from the transverse processes of your lumbar vertebrae, all 5 of them. The insertion will extend underneath the inguinal ligament to then insert on the lesser trochanter of the femur. The innervation of your psoas major muscle will be the anterior rami of lumbar spinal nerves L1, 2, and 3, and the primary function of the psoas major is to flex the femur at the hip. It is a very powerful flexor of the hip. The psoas minor is a small muscle that runs on the superficial aspect of the psoas major. This muscle may be absent in some individuals. Its points of attachment would be the lateral surfaces of the bodies of T12 through L1 and the intervening intervertebral disc. Its insertion is more inferior and would be to the pectineal outlying region of the pubic bone. It's innervated by the anterior ramus of the first lumbar spinal nerve, and its action is to produce weak flexion of the vertebral column. The next muscle to take a look at is our quadratus lumborum. It's a quadrate-shaped muscle in the lumbar area, and that is visualized in the illustration right in through here. The attachment of this would be to the transverse process of L5, the iliolumbar ligament, and then the iliac crest. It also attaches for its points of insertion to the transverse processes of L1 down through L4, and also has an attachment for its insertion to the 12th rib. This muscle is innervated by the anterior rami of T12, L1, L2, L3, as well as L4, and its main function is most likely to stabilize the 12th rib during respiratory movements. The diaphragm also has an attachment to the 12th rib, and so when it's contracting during inspiration, it wants to pull that 12th rib superiorly. What will happen then to counteract that is that your quadratus lumborum will contract and stabilize that 12th rib to keep it from being pulled more superiorly by the action of the diaphragm. The last muscle to point out with respect to the posterior abdominal wall is your iliacus muscle. It is shown right in through here. It is originating from the internal surface of the iliac ala, or the wing of the ilium. Also has a partial attachment to the sacrum and some associated ligaments in this region. It has the same point of insertion as does the psoas major. It inserts onto the lesser trochanter of the femur. Collectively, the psoas major and the iliacus are known as the ilio-psoas, and since they both contract to the same point, the function of the iliacus is the same as the psoas major, a powerful flexor of the femur at the hip. The nerve that innervates your iliacus will be the femoral nerve, and the femoral nerve would run on the lateral margin of the psoas major. Welcome to this lecture on the abdominal wall. This slide lists the objectives that you should be able to answer at the conclusion of this presentation. First, list the muscles of the anterolateral and posterior abdominal walls. Describe the attachments, innervation, and action for each muscle. Describe the rectus sheath and how the arcuate line is formed. Describe the arterial supply to the abdominal wall. Describe the anatomy of the inguinal canal. Define the boundaries of the inguinal triangle. And lastly, anatomically distinguish a direct from an indirect inguinal hernia. And then we'll proceed to the summary slide and identify the important take-home messages. And then lastly, provide attribution for the images that were used throughout this presentation. We'll stop momentarily here to point you out on the body map, our area of attention or focus. Here is the anterior abdominal wall, so we'll be looking at this region of the body, outwards here laterally, and then we'll also want to take a look at the posterior abdominal wall as well. This slide depicts the muscles of the anterolateral abdominal wall. These muscles consist of 3 pairs of flat muscles, and then we have 2 pairs of vertically oriented muscles. The flat muscles are the external abdominal oblique, the internal abdominal oblique, the transversus abdominis, and then our 2 vertically oriented muscles will be the rectus abdominis and then a very small pyramidalis. And again, all these muscles listed here are paired, so we have right and left muscles. Let's take a moment to look at each one of these muscles individually. And when we do so, our interest here will be on describing the attachments of the muscles, their innervation, and their actions. So our first stop will be the external abdominal oblique. And I want to highlight the fact that we can see those fibers here. These fibers are running in the same direction as the external intercostal muscle fibers that are a part of the thoracic wall. That means they're running down and in, and they will attach to this whitish sheet that we see here, and this is the aponeurosis of the external abdominal oblique, and then that aponeurosis will course toward the midline and help to form what is known as the rectus sheath, and we see the rectus sheath right in through this particular area. The attachments of the external abdominal oblique, points of origin are going to be here more superiorly. The external abdominal oblique is going to arise from the outer surfaces of ribs 5 through 12. And then the insertion of the rectus will be to the aponeurosis, ending in the midline here, the linea alba, and also to the iliac crest. The innervation of the external abdominal oblique will be from anterior rami of the inferior 6 thoracic spinal nerves. So we're looking at anterior rami from T7 all the way down through T12. The actions of the external abdominal oblique. Let's first think about both the right and the left external abdominal obliques contracting. That will help flex the trunk of the body like so. We can also consider these working unilaterally. So if just the right external abdominal oblique contracts, it can help the body laterally flex to bend toward the same side. It can also help to rotate the torso, and for the external abdominal oblique, if it's contracting, it will rotate the right side. If it's the right one contracting, it will rotate your right anterior abdominal wall toward the left side of your body, like so. In addition, the rectus abdominis, as well as the other two flat muscles of the anterolateral abdominal wall, will help to compress the abdominal viscera, as well as protect the abdominal viscera. The internal abdominal oblique lies immediately deep to your external abdominal oblique. And if we take a look at our diagram here, or illustration, the internal abdominal oblique is shown right along in through here. The cut edge of the external abdominal oblique is right along here. And now we see the fibers of the internal abdominal oblique. They are running down and out. This is the same orientation that the internal intercostal muscle fibers have within the thoracic wall. Here, more anteriorly, we can see that the muscle fibers are ending in the aponeurosis of the internal abdominal oblique, and that aponeurosis will extend toward the midline of the anterior abdominal wall and end within the linea alba, and will also contribute to the formation of the rectus sheath. The attachments of the internal abdominal oblique, more posteriorly and out of view here, would be to the thoracolumbar fascia. It also will have a point of origin from the iliac crest, and it is going to attach for its point of origin along the inguinal ligament, and the inguinal ligament is formed by the aponeurosis of the external abdominal oblique. Its insertion points will be to the inferior ribs, and we're looking at the inferior 3 or 4 ribs, so that would include 12, 11, and 10, and perhaps even rib 9. It would also insert into the linea alba, as well as to more inferior portions associated with the pubic bone. The innervation of the internal abdominal oblique will be by the anterior rami of the inferior 6 thoracic spinal nerves, T7 through T12, and it also picks up additional innervation from the anterior rami of L1, the first lumbar spinal nerve. The actions of the internal abdominal oblique, if both are contracting, both will help to flex the trunk, just like the external abdominal oblique. The internal abdominal obliques help to protect and compress the abdominal viscera, just like the external abdominal oblique. If just one side is contracting, let's say the right internal abdominal oblique, it will help to bend toward the same side or laterally flexed. And it will help rotate the anterior abdominal wall in this direction. So if it's the right one that's contracting, the right side of the anterior abdominal wall rotates toward the same side, thereby pulling the left over toward the right. The transversus abdominis muscle is the deepest flat muscle of the anterolateral abdominal wall. It is visualized over here on this side of the image. This portion that we see here, the muscle being reflected, that belongs to the internal abdominal oblique. We can see the transverse or horizontal orientation of the muscle fibers of the transversus. They end within an aponeurosis as well. This aponeurosis extends toward the midline and will also contribute to the formation of the rectus sheath. The attachments of the transversus abdominis are going to be posteriorly, so out of view here, to the thoracolumbar fascia, in addition to the iliac crest, points of attachment shared with the other two flat muscles. It will also have an attachment to the inguinal ligament, that inferior ending or termination of the external abdominal oblique, and it will also have points of origin from the costal cartilages of your inferior ribs, usually the inferior-most costal cartilages of the 6 ribs here. Its insertion will be into its aponeurosis, which extends into the linea alba, will also attach to pubic bone structures such as the pectineal line. Innervation of the transversus will be the inferior 6 spinal nerves again, T7 through T12, and their anterior rami, and it also will receive a contribution from L1. Actions of the transversus abdominis, because of the transverse or horizontal orientation of these muscle fibers, the primary function of this muscle is to compress the abdominal viscera as well as to protect the abdominal viscera.
Let's talk about what happens if an oblique strain gets injured. This happens typically when one of both obliques are overstretched or partially torn. This can be caused by flexion, lateral flexion, or twisting. A typical symptom of this injury is a sudden, sharp pain around the rib cage. This pain is exacerbated when sneezing, coughing, and deep breathing.
This slide is introducing us to the concept of the rectus sheath. The rectus sheath is a sheath that will surround or invest the rectus abdominis muscle. The rectus sheath is going to be formed by the aponeuroses of the 3 flat abdominal muscles that we just described, the external abdominal oblique, the internal abdominal oblique, as well as our transversus abdominis. The orientation of these aponeurotic components will vary depending on if we're above the umbilicus or for about halfway between the umbilicus and the pubic bones. If we take a look at some of the profiles that we have here, we have 2 profiles that are at and above the umbilicus. And then this axial section that we see in through here is at a point that's about halfway between the umbilicus and the pubic bone. If we look here at this upper portion of the figure, we see our rectus abdominis right in through here. We see that it is completely invested anteriorly and posteriorly by aponeurotic fibers. So it's completely surrounded by a rectus sheath at this point. Same thing is true with this middle axial or transverse section. Contribution to the rectus sheath is from here, the aponeurosis of the external abdominal oblique. It completely will run anterior to your rectus abdominis muscle, meet in the midline here, the area of the linea alba, and then intermix with the aponeurotic fibers from the opposite external abdominal oblique. Your internal abdominal oblique is this middle muscle layer. It has its aponeurosis beginning right about here, and the aponeurosis of the internal abdominal oblique will split. Some of the fibers will run anterior to the rectus and then meet and intermix with the opposite fibers of the internal abdominal oblique aponeurosis. And then the other half of the aponeurosis of the internal abdominal oblique will run posterior to the rectus and then intermix in the linea alba with those from the opposite side. The transversus abdominis is your deepest layer, and we see it running right along here. It too has an aponeurosis, and at this level of an axial section, all of its fibers are running posterior to the rectus, will then intermix with those from the opposite side in the area of the linea alba. Now, if we get inferior enough with our axial section, we will see a difference in the orientation of these aponeurotic fibers or sheets. And if we take a look here, here's your external abdominal oblique, internal abdominal oblique, transversus abdominis, And if we come more toward the midline, we see all the aponeurotic fibers converging here, and they will all run anterior to the rectus abdominis. So there is no longer a posterior component or contribution or lamina to the rectus sheath. It is devoid in this inferior location. Where you see a transition of the rectus sheath lying anterior and posterior to where you only have it lying anterior to the rectus abdominis, you will see an arcuate line. That arcuate line is depicted in this image, and if you remove your rectus from the view, the right rectus has been cut here, and the two ends partially reflected. Here is the rectus sheath that lies posterior to the rectus abdominis. Here is the inferior margin of where that posterior lamina ends. And then you see that it is the arcuate line that defines that termination. And then if you go below that, this area here is devoid of the posterior portion of the sheath or lamina, and all those aponeurotic fibers at this level were running anterior to your rectus abdominis. At this point below the arcuate line, the membrane that you see here belongs to the transversalis fascia. Now, the rectus abdominis muscle specifically will have attachments, will have its own innervation, as well as produce some various actions. The attachments for origin are going to be inferior, and those points of origin will include the pubic bone as well as the pubic symphysis. The points of insertion will run more superiorly, and those will include the costal cartilages of ribs 5 through 7 typically, and the midline structure being the xiphoid process. Innervation to the rectus abdominis will be by anterior rami from the inferior 6 spinal nerves, so T7 through T12, and the actions of the rectus are to help produce flexion of the trunk of the body as well as to compress abdominal viscera. This brings us to the last muscle, or last pair of muscles that belong to the anterolateral abdominal wall, and this would be the pyramidalis muscle. This is relatively unimportant functionally, and it may be absent in some individuals, but it is this very small muscle mass that we see here inferiorly located in the illustration. It lies deep to the rectus sheath and would occupy a region between the rectus abdominis muscle itself and the anterior lamina of the rectus sheath. You can see it is shaped like a pyramid. This is just the left one. You would have a right one on the opposite side as well. Attachments of this muscle are from the pubic bone and pubic symphysis, and it inserts into the linea alba, which is this region right in through here. Functionally, it is said to tense the linea alba, but again, this is relatively unimportant. Its innervation is from the anterior rami from your 12th thoracic spinal nerve. And now let's transition to the arterial supply to the abdominal wall. This slide is demonstrating two arteries that run on the deep aspect of the rectus abdominis, and these are epigastric arteries. The first one is located right here, and you can see the rectus abdominis right along here. This is the superior epigastric artery. It is a branch of a thoracic artery called the internal thoracic that we see here along the lateral margin of the sternum. And then at this point, that internal thoracic branches into a musculophrenic, and then a more medial branch that is directed vertically into the abdominal region to help supply the rectus abdominis. Another deep epigastric artery is referred to as the inferior epigastric artery. We see it coursing upwards along the deep surface of the rectus abdominis. The source of the inferior epigastric artery is your external iliac artery that is labeled right at this particular point. And then the two epigastric arteries will anastomose within the substance of the rectus abdominis. We also have some additional arteries that supply the abdominal wall. 3 of these are listed on the slide: the superficial circumflex iliac artery, the deep circumflex iliac artery, as well as the superficial epigastric. So let's take a moment to identify those particular vessels. Here we have our external iliac, and then on the deep aspect here, running along the ilium, is the deep circumflex iliac artery. The external iliac then will pass deep to the inguinal ligament, which we see here, and it'll enter the femoral triangle. And as it enters the femoral triangle, we will refer to this artery as the femoral artery. It will give rise to a superficial circumflex iliac that we see branching off at this point, and will run more superficially in this general vicinity. This branch that we see here is also issuing from the femoral artery. This is the superficial epigastric artery, and it will have a subcutaneous course on the anterior abdominal wall. Please bear in mind that this is not an exhaustive list of arteries that supply the abdominal wall. We have some others as well. For example, we would have 4 pairs of lumbar arteries that would issue from the aorta above here that would travel on the posterior abdominal wall and then start to follow the lateral aspects of the wall and start to anastomose with some of these other vessels. We also have an ilio-lumbar artery, which we see coursing up vertically along the sacrum. This is issuing from the internal iliac that we see here, and we certainly would have some other contributing blood vessels that would help supply the abdominal wall. Innervation to the anterolateral abdominal wall, as mentioned earlier, is provided by anterior rami of T7 down through T12, as well as L1 for muscular distribution. In addition, these anterior rami also will have a dermatomal pattern of distribution, and this just gives you a general idea of where those anterior rami are running or traveling within the abdominal wall. Here's the level of T7. It is going to relate to the level of the xiphoid process. T10 is emerging in through here and will relate more medially to the umbilical area. And your most inferior dermatomal contribution, L1, that is seen down below here, that is going to run along the inguinal region. Innervation to the muscles of the posterior abdominal wall are going to be from anterior rami of your spinal nerves as follows. You would have T12 and L1 through L4. The Quadratus lumborum, shown in through here, is innervated by all of those segmental levels. The psoas major, which is seen on the opposite side, would be innervated by L1 through L3 levels. The psoas minor, which we see here, the muscle belly is very thin. We see the tendon of the psoas minor. It will be innervated by L1. The iliacus, which we see over in through here, is innervated by the femoral nerve. The femoral nerve in its entirety is formed from contributions of L2, L3, and L4. We can also visualize and highlight some of these rami. Here at this level, we're at the 12th rib, and we see a nerve penetrating the substance of the quadratus lumborum. It would help innervate it. Would also have that anterolateral distribution that we saw on the previous slide. This is the T12 anterior ramus, also known as the subcostal nerve. Here we have the L1 anterior ramus, and at this level it is split into an iliohypogastric nerve above and an ilioinguinal nerve below. L2 is here, L3 is coming out at this level, and then L4 is emerging at this particular point in the illustration. Next, we'll take a moment to understand the inguinal canal and the features that you see to your left, the inguinal ligament, the superficial inguinal ring, lateral crus, medial crus, and intercrural fibers are all demonstrable on this particular illustration. The inguinal ligament is the inferiormost aspect of the aponeurosis of the external abdominal oblique, and we see that inferior margin running along here. It attaches laterally and superiorly to the anterior superior iliac spine, and then its medial inferior attachment would be to the pubic tubercle. In this medial location, along this region, we see an opening within the aponeurosis. This happens to be the superficial inguinal ring, and on the medial side of that, we have a medial crus, and on the lateral side, we have a lateral crus, and then we have these interdigitating fibers interconnecting those two crua, and those are the intercrural fibers. In a man, the major structure that we see here traveling out through the superficial inguinal ring is the spermatic cord. The spermatic cord enters this region by passing internally through a deep inguinal ring, and as it travels through the inguinal canal, it will pick up all the layers that we see eventually emerging through the superficial inguinal ring. When we think about the inguinal canal will present two walls. It'll also have a roof, and it'll also have a floor. So what we want to do now is to explore the components that form the anterior wall, the posterior wall, the roof, as well as the floor. Using the same image as the previous slide, our focus here is on the anterior wall, and the anterior wall has been reflected, so we are looking into the inguinal canal itself. So let's take a quick look at some of the landmarks here. This is your deep inguinal ring, and you see some vascular structures passing through the deep inguinal ring. This muscular structure that we see here in a man is the ductus deferens. So it passes through the deep inguinal ring and is now traveling within the inguinal canal. And then it passes through the superficial inguinal ring at this particular location. The anterior wall has been reflected. Contributing structure to the anterior wall is the aponeurosis of the external abdominal oblique, which we see in through here. And there's also going to be a lateral reinforcement from the internal abdominal oblique muscle. So right in through here, and this would be the lateralmost aspect of your canal. It too is being reflected away from the canal. The posterior wall is that area that we see in this general vicinity. The fascial component that we see that would pass behind the spermatic cord contents that we see at this level is the fascia of the transversus abdominis. This is referred to simply and aptly as the transversalis fascia. More medially here along the posterior wall and not visible at this particular point in time is a tendon referred to as the conjoint tendon. It is formed by the aponeuroses of the internal abdominal oblique as well as the transversus abdominis. So that helps to reinforce the medial third or so of the posterior wall. The roof of the canal has been opened up, so we're looking down into the canal yet again, but the roof of the canal will be formed in part by your internal abdominal oblique, which is reflected here, and then your transversus abdominis that we see at this level. And then lastly, we'll have the floor to the inguinal canal. A good portion of the floor will be formed by the inguinal ligament. And as that inguinal ligament approaches its medial attachment to the pubic tubercle, there will be an expansion of the inguinal ligament that will run more posteriorly to attach to the pectineal line of the superior ramus of the pubic bone. This expansion of the inguinal ligament more medially forms what is known as the lacunar ligament, so it will contribute to the floor as well. Again, there's some additional geometry that we can learn about in the discipline of anatomy, and the inguinal region is no exception to that. Here we're looking at the inguinal triangle, also known as the triangle of Hasselbalch. This triangle is bounded inferiorly by the inguinal ligament, which is running right along here. So that would actually form the base of our triangle. Another portion or boundary to our triangle is the lateral margin of the rectus abdominis that we see along here. And then this boundary or border to the triangle is formed by the inferior epigastric vessels. So again, we have a nice geometric triangle formed by those three structures. Understanding the inguinal triangle is useful in one understanding the difference between a direct and an indirect inguinal hernia. Here we have a herniation of intestinal loops into the scrotum. This is more common in men, but we can have an inguinal hernia occurring in women. The difference between a direct and an indirect is the relationship that the intestinal loop will take to enter the scrotum. In the profile or image side here on our right, we have in reference, we have our inferior epigastric vessels, the artery as well as the vein. And here we can see a herniation of an intestinal loop into the scrotum, and it takes a direct route into the scrotum because it passes medial to your inferior epigastric vessels. The left side of the image shows an indirect hernia. Here the intestinal loop is passing lateral to those inferior epigastric vessels. Therefore, it will pass into the inguinal canal and will have to exit at the level of the superficial inguinal ring, which is at this general location. And then once it passes through the superficial inguinal ring, it can then herniate into the scrotum. That now brings us to the important take-home messages from this presentation. First, the muscles of the abdominal wall are innervated by anterior rami from levels T7 all the way down through L4. Collectively, attachments are to the thoracic cage, pelvis, and femur. Anterolateral muscles compress the abdominal viscera and function in lateral flexion and rotation. The most powerful muscles of the posterior abdominal wall, the psoas major and iliacus, flex the thigh. The inguinal canal is a potential point of weakness, allowing for direct or indirect herniation of intestinal contents. The inguinal triangle is bounded by the inguinal ligament, inferior epigastric vessels, and the lateral margin of the rectus abdominis. And lastly, direct hernias pass medial to the inferior epigastric vessels, whereas indirect hernias will pass lateral to that vasculature bundle. Thank you for joining me on this lecture on the muscles of the abdominal wall, as well as its vasculature and innervation.